slides and our headlines on the budget and what we know about some of the measures in not too much detail, but certainly a little bit more detail than perhaps some of the overviews you've seen so far. Let me just get that right. That way. Okay, so just in terms of an overview, well, the first thing to say is that it is a budget, the elements of which won't be implemented if the government bringing down this budget isn't returned. So it's unusual circumstances in that sense. So that's the first point. We're looking at spending of around $435 billion over the next 4 years on health, $20 billion in extra funding for health, aged care and sport, so across the health and aged care portfolio. Look, our assessment is that there's a spread, a myriad of initiatives, as we've described them, across the budget, something for everyone, you could argue, but no significant, really transformational measures, but measures that in their own right make major contributions to many significant health issues. Most of the individual measures we're about to take you through had previously been announced, and they broadly sort of cluster into 5 key areas: guaranteeing Medicare and access to medicines, ageing and aged care, no surprise to see that one in there, supporting hospitals, prioritising mental health, prevention, health and sport, and life-saving medicines and job-creating medical research. So just again, top lines. One of the interesting ones for us was the additional investment in primary care. We can always argue whether that was sufficient level of investment, but we do see some new money for a new primary care enrolment model to improve coordination and access to care. Talk about that a little bit more in a minute. That'll allow clinicians to provide services without face-to-face consultations. So that's a measure that's long overdue from a patient access and patient convenience point of view. It is a game changer because it breaks us between the current Medicare rules that say that a Medicare rebate can only be payable when there's a face-to-face consultation with a patient. That's no longer the case with this model. Additional funding in mental health, quite a lot. An interesting one in there, a trial of 8 adult walk-in mental health centres, designed to address a gap in the service system there. Increases, 6% increase in funding for aged care services, while welcome, and we'll talk about a little. No, it's all right. There we go. Another headline was the improved access to diagnostic imaging through the removal of freezes on rebates and some provision of. So the return of indexation for diagnostic imaging should help with out-of-pocket costs for consumers. And then there's some continued commitments to providing access to subsidising medicines through PBS and the Life Saving Drugs program. They're sort of headlines. We'll go through some detail now. We'll also cover off what's missing in this budget from CHF's perspective at the end of this presentation. So the first theme, guaranteeing Medicare, quite a few measures in there. The diagnostic imaging measure that I was talking about, indexation, return to indexation for imaging tests and screenings, heart health checks, commitments to implement some quite specific areas in the MBS review, improved transparency of out-of-pocket costs. That's referring to the transparency or price disclosure website that arose from the ministerial out-of-pocket cost steering committee. My Health Record, continued investments in that area, some continued investments in some new registries for cardiac, breast, hip fracture and trauma, just so that consumers, or not so much consumers, but clinicians and others, I don't think these are accessible, searchable by consumers, have better accessible information about the performance and safety of devices. So drilling down into some of the expenditure under that guaranteed Medicare banner, there's a basket of things, $926 million you'll see there. That includes an addition of $445 million over 3 years for a new funding and service model to support care coordination and flexible care for people over 70 years. So that's basically a form of patient-centred healthcare home, you could say. It will give people over 70 the option of enrolling with a GP, and part of that process will see GP practices paid in different ways to fee-for-service ways to deliver non-face-to-face care and more packaged up or care coordinated across a sort of an illness course funded in ways other than fee-for-service. There's some funding in there for a new quality-focused incentive payment for general practices. That rolls together and replaces quite a lot of individual incentive practice payments that have been in place. We'd like to think that there's room to tie in there somehow, particularly if this is about incentivising practices to take improvement steps to the way they deliver care, a greater focus on the use of patient-reported experience measures, for example. And then, of course, the other expenditure item in there is the increased patient rebates for quite a few GP services from 1 July this year, matching the ALP commitments. So we've got both parties there matching each other to unfreeze the indexation on Medicare rebates. That's just a breakdown, an even further breakdown. Medicines? Okay. Hi, everybody. Just remember that you can put your questions in, and we'll take questions right at the end. So that if you type your question in, then at the end of the presentation, we'll take as many questions as we can. There's $40 billion for medicines over the forward estimates, so over the 4 years. This is a continuing commitment from this government that they will list new medicines as they're recommended, and this we know is an important initiative for most consumers. I think we're very lucky to have the PBS, and I think most of us would agree. And so this is a commitment that as new medicines come up, they will get listed once PBAC has recommended them. So it still has to go through. I think it's important to remember that medicines will still have to go through the PBAC, the Pharmaceutical Benefits Advisory Committee process before they get recommended for subsidising. The listing of a new drug on the life-saving drug program is welcome. I mean, at one point we thought we were going to lose the life-saving drug program. There was a review, which some of you might remember. The government recommitted to that a couple of years ago, and so this is an extra drug on that. The life-saving drug program, for people who are not familiar with it, is for drugs that don't meet the PBAC standard of cost-effectiveness, but are seen to be necessary and, as the name says, life-saving for people with rare diseases. So they're for rare diseases. They're often very expensive drugs that without the subsidy people could not afford to use themselves. So they make huge difference to both the length of life of people living with some of these rare diseases and the quality of their lives. So I think that's important. Community pharmacy is a winner, with additional funding and support through increased dispensing fees and streamlined payment processes. There's, as many of you will be aware, we are going to be renegotiating the community pharmacy agreement to start middle of next year, so negotiations will start. And so this is in advance of any new agreement, some additional funding to meet the costs, particularly the costs of more expensive medicines
as medicines get more expensive, pharmacies have to fund them. And so this is to try to reduce the cost, which for consumers should mean that it's better access to those more expensive medicines. We're also see an increase in funding for some of the quality use of medicine programs delivered through community pharmacy, particularly for dose administration programs and reviews. And those are both welcome measures, I think. And the continued commitment to the stoma application. And on the next slide, you'll just see, if you haven't already seen it, just a summary of the expenditure. Significant expenditure, you know, 331 million for new and amended listings on the PBS, $500 million for pharmacy, expansion of the glucose monitoring program, whilst relatively small, is important for the people that it works for. And I think we sometimes forget that in the big numbers, we need to look at the smaller numbers as well. So there's that. So that's medicines, and it was pretty much just more of what we're used to. There was nothing new or innovative in the medicine program. Then we'll go to prevention. I think prevention is probably, it's fair to say, the most disappointing part of the budget. There wasn't a lot of major new initiatives in prevention. There was extension on dental. The only thing that we saw was that the current child dental benefit scheme is continued for an extra period of time, but not with additional funding or additional coverage, just continuing on. We had a whole of government drug and alcohol strategy, but nothing, again, pretty limited in what it did, but it's a start. They put funding for cancer research and treatment into prevention, which I think is interesting in the terms of the treatment. I think for the research certainly, but to put the cancer treatment into prevention, I think is showing that maybe. But cancer is obviously cancer treatments, and particularly they're interested in some of the rarer cancers and looking at treatments that will help people with those, and you know, we certainly support that. The prevention, testing and treatment of bloodborne viruses and sexually transmissible infections, that is an important measure. I think there's still some work to do, but I think that's generally been well received by the sector as being where we can make a real difference to preventing such viruses and to treating them. And so that now these are treated, what were seen as life-limiting diseases in the past have now moved into the chronic disease framework of people getting treatment that allow them to live their lives while they still have the disease. But we need to do more to prevent them. There's some money for an anti-smoking campaign. We need to keep up the effort. We're doing really well on anti-smoking in Australia, but we obviously need to do more. Probably the area where we were most disappointed was the minimal action on obesity. Or there was very little mention of obesity, despite the fact that we recently had a national obesity summit co-chaired by the Senator Bridget McKenzie and the Minister for Health from Queensland. But the only action there was some funding for the current health star rating system. No, and I think this is the area where all sides of politics and where we need to have some action on obesity. Those who saw a press club event on the health panel with Sandro Demir would have seen that he was a call to arms on childhood obesity in particular, that we need to do more. And so I guess that will be one of our agenda items to take up with whoever forms the next government.
And in the context of the election,
yeah. So I think that was probably, and then training primary care providers to respond better to violence against women and children. Critical issue. We need our primary care providers, who are the first port of call, along with emergency departments, obviously, to recognise when somebody might be a victim of domestic violence and be able to help people find the right sort of services for them. And just, it's the recognition that is often the problem there. And as when you look at the expenditure slide, there's a lot of issues. There was the child benefit schemes. There were all the ones we've talked about. There was also supporting Australians living with epilepsy, which is a critical issue. $20 million over 4 years is, I'm sure, for people with epilepsy is significant and will hopefully improve their quality of life. The next part that we'll go to is aged care, and I guess we might have been hoping for a bit more on aged care, given that we do have the Royal Commission into quality and safety in aged care underway at the moment, but that Royal Commission has got to go now. I think it's got at least another 15 months before it's 15 to 18 months before it's due to report. Well, there was a one-off increase in aged care funding to residential aged care, in recognition that the funding is probably not adequate. And this is, we've put pending term reforms and the outcomes of the Royal Commission. There is some work underway within government to look at a new way of funding residential aged care and a new funding assessment tool. This will be, every so often we have one of these. And I think it'll be informed by what the Royal Commission throws up in terms of where people see the gaps and how do we provide the quality services that we need, and how do we make sure the money goes to where it should go. And I think that's the work of the longer term reform on the funding instrument. There was a raft of issues on enhanced monitoring and strengthening of regulation in aged care, looking at some clinical indicators, looking at how visits are undertaken. This is obviously, again, a work in progress once we get the Royal Commission interim report, once the Royal Commission has finished having its first round of hearings and submissions and starts making recommendations. And I think all of us support better quality in aged care. Particular issue of interest to us, and I know to many people in our sector, is the use of medicines in aged care, and you know, the misuse and the overuse of certain types of medicine, and monitoring, and how many people are on sort of polypharmacy, how many people are on multiple medications, and how these are reviewed and when they're reviewed. And we think that the measures to use pharmacists to help reduce the misuse of medicines in aged care is important. The trial for in-place pharmacists in residential aged care is a great move. CHF has been arguing for pharmacists in general practice for similar reasons, where you have a congregate community of people who are high medicine users, then it makes sense to have a pharmacist who not just sort of come in and, but somebody who might get to know the patients and might get to know the residents of residential aged care, and so work with the staff to look at what the medicine use is and whether it's appropriate. And I think that, you know, is part of improving the quality of care for people in residential care. And the most disappointing part of this, which to some extent is in our missing bit, is that there was no increase in home care packages. I know the Council of the on the Aging, who is a member of CHF, has commented on this in more detail. But this is unfortunate because there's a huge waiting list for aged care places. There's about 130,000 people on the waiting list to get a package to stay at home. And that's just, I think, in any other area of healthcare, that would be seen as unacceptable and would have urgent action. And I know COTA and others are urging for on that measure. And if you're interested, you can go and check out what they have to say about that. And there's just the money. It's a lot of money. Aged care is a lot of money. I think the Royal Commission will show that we're probably going to need to, as a society, spend more, invest more. And I think that will be an interesting element of next round of work that has to be done. So Leanne's going to take you through the next part.
Digital health. Well, look, I think it's fair to say that we had a very, some might say, tumultuous year, previous few months with My Health Record, change to the legislation there to strengthen its fee and protections, all of which we welcomed. But digital health is obviously a lot more than My Health Record, even though My Health Record is an important part of where we want to see a modern healthcare system go, particularly a My Health Record that has the right data on it and is offering consumers and clinicians with something that's got high value and high utility. That's going to be something that really makes it worthwhile. It's one thing to get the infrastructure for a My Health Record established. It's entirely another thing to stimulate use, encourage use of it, encourage awareness of it, ensure that clinicians have trust in it, ensure that trust in it. So under the broad digital health banner, there are a number of continuing things. Basically, there's $200 million for the Digital Health Agency, just as part of its ongoing annual budget to just allow it to keep doing its work. But that work will be focused on a number of things now, as we understand it. Certainly, it'll look at continuing to evolve and bed down the My Health Record. So there's going to be a lot of work happening to improve and get more diagnostic and pathology test results in there, make the clinical notes and other aspects of its functionality more consumer friendly and usable. There'll be work to on interoperability within the system. The Digital Health Agency just released a consultation paper on that whole issue at the moment. Interoperability isn't a very easily understood term for consumers, but what they're actually talking about is trying to get us to a point where, if you imagined what an Australian hospital, for example, in 2030 might look like, what sort of connected up information and what sort of digital enablements to care should be in place. It's really planning for that, and that's an important conversation, an important consultation for consumers and our sector to be involved in. There's other aspects to the National Digital Health Strategy that is a COAG endorsed initiative that the agency will be moving to implement. So there's a series of what they call test bed sites where they're looking at using digital health to modernise healthcare delivery. One of the most advanced ones that we're familiar with is the National Child Health Digital Collaborative, where they're looking to digitise the baby record, looking to harmonise records, baby health records across the country. So quite practical measures that just make the system a bit more connected up and digitally enabled. So just on the next slide there, it was described in the budget papers as 200 million for continuation of the My Health Record, but it's actually more than that. It's to support implementation of various aspects of the National Digital Health Strategy.
And now if we move to public hospitals, the government announced a significant amount of money, investing 1.25 billion in local services infrastructure projects under the Community Health and Hospitals program. This is designed to look at work with the local community, work with the PHN and the hospitals, the state and territory hospital network, to identify where there are gaps and where there might be a useful injection of additional money. It's sort of got a wide range of services. It looks at 4 key areas: specialist hospital services such as treatment for cancer, rural health and hospital infrastructure, drug and alcohol treatment, preventive disease management, and mental health. They've already identified projects to fund and show you the range of things that that this program is funding. It's includes the comprehensive children's cancer centre at the Sydney's Children's Hospital, at the additional funding at the Peter MacCallum Centre we're very happy with that. And the additional infrastructure for hospitals is similar, to try to improve access to a range of services. I guess our criticism of this package is that it appears to be a fairly piecemeal approach, and it's not clear what processes were used to decide what the priority projects were. But if they were generated out of local needs assessments, then I think that would overcome our criticism of that process. So the budget papers themselves will a breakdown on how this money was actually spent.
Okay, so now to mental health. This is a big area of expenditure. I think what we're seeing here is a reflection of the current minister's big passion and commitment for improving and extending services in this area, which we of course welcome. It's a high need area in the community. As you know, or you may not know, there's a big productivity commission review and inquiry on at the moment, looking into mental health and gaps in service delivery there, and how our mental health investments contribute or not to national productivity and people getting well and people getting on the right pathways to treatment. It also reflects, I suppose, a pledge we saw from Greg when he first took up the post of Minister for Health, where he talked about his waves reform and primary healthcare reform and mental health care investment were his third wave. So this is what we're seeing here in a total investment of around $750 million, additional investment in mental health. Sort of a life course approach being taken here, as you can see on that slide. Investment in services ranging from perinatal mental health and wellbeing programs and services through to more expansion of the headspace and early psychosis youth service initiatives. I think we're going up to, I can't remember the number, but quite an enormous number of headspace services in the community. And enhancements to the way mental health is delivered in the community to adults. So there's some investment here in starting to try out walk-in or drop-in adult community-based mental health services, a little bit like the Headspace model from what we can gather. We're quite welcoming of that as a concept, a bit intrigued by it at the same time. It probably won't be for everyone, and it will be important for them to be locally designed and well integrated with other step up and step down services, and also obviously comorbidity, physical mental health comorbidity, and how we are more effectively managing that and responding to that in the community has got to come into play here if it's a drop-in community-based mental health service model that we're trying out. And then there were some quite specifically targeted measures in here to workplace-based, like real settings-based approaches to mental health, and also some disaster response expenditure to very targeted community needs like the Tartar bushfires, the Townsville floods, that sort of thing are all part of the expenditure here as part of a natural disaster assistance package for mental health. So you can see where the expenditure items cluster together there. Community mental health service, the adult walk-in centres, as I said. Some big investments there too in residential eating disorder treatment centres. That was a previous announcement. That's an area of mental health disorder that often doesn't get the headline like some of the higher prevalence or lower prevalence, but more disturbing conditions like psychosis do. But it's one that has an enormous impact on life and recovery. So we welcome that. And some really good measures there too in the next line down, 461 million within that bundle. There's some investment in Indigenous suicide prevention. You would have to be a bit of a mushroom, I guess, not to have heard all these stories about the rates of young people suicide among young Indigenous people, and some good measures there to get better information about suicide hotspots so that more targeted responses can be put in place, and then some good investments into some existing community-based parent and family support, things like Kids Helpline, which is well known, and the Raising Children's Network, which is a very good website. Then over to Indigenous Health, $10 billion over 10 years of investment there. Of course, we welcome that. The other thing we've done today as CHF is to put out our endorsement of the Uluru Statement from the Heart about supporting the need for the Indigenous community to have a voice in Parliament and constitutional change, because as we all know, advancements in Indigenous health, yes, we'll get a contribution to that from health service and more community-controlled health services that are tailored and responsive to needs, but some of the real fundamentals there are the social determinants of health, and we think that Uluru's statement and that being acted on by the new Parliament is very, very important.
The last area that was highlighted in the budget was research, and while that obviously has a longer term impact on us all, it is important. They announced the 10-year investment plan for the Medical Research Future Fund, which is looking at specific research missions. It's looking at access to around rare cancers, rare diseases and unmet needs. And I think there is running through a number of the budget initiatives is an acknowledgement. Rare cancers and rare diseases have probably missed out in a lot of the funding, and obviously been some successful raising of the issues by member organisations such as Rare Voices and Rare Cancers Australia to highlight the need to look at these sometimes are areas because it's few people, it doesn't attract enough attention. Research infrastructure, funding researchers, and probably important is translating research for rapid application. I think it's the Medical Research Future Fund is really trying to push the idea that there's translation, that you don't do research just for the sake of doing research, you do it to get a tangible outcome. And I think the translation part of that is important. The government also announced is the establishment of a new Health and Medical Research Office, which will have its own CEO, and what its relationship will be with organisations like the NHMRC or the Department of Health. But the CEO will be appointed, I think, to work with the Secretary of the Department of Health according to the budget papers, but it's not clear how that sits in terms of everything else. But I think moving it to a specific office that has research expertise and understanding and can call upon expertise in translation and prioritising of health. And many of you know that we, along with others, have been pushing for consumers to be more involved in health research. And one of the things that we would probably want to do is the Health and Medical Research Office gets up and running. And it does depend on who wins the election. We want to talk to them about how consumers will be engaged and how they intend to let consumers be involved in the research, not just at the end of being the subjects of research. And I think that's important for us. And so we're quite intrigued, I suppose, is the word on that one as well. And Leanne's already touched on the funding towards Indigenous health priorities. So research into Indigenous health, that's particularly important. We give funding to guarantee the Lecture Institute viability. There's quite a lot of money. If we look at the slide with the funding on it, there's quite a lot of money in 170 million over 3 years for funding on Indigenous health, rheumatic heart disease, avoidable blindness and avoidable deafness. And I think the words are avoidable. If they're avoidable in the rest of the community, then they're also avoidable for the Indigenous population. And we need to look at that. And rheumatic heart disease, I think, is a priority. It's completely avoidable, and hardly anybody other than an Indigenous person gets rheumatic heart disease in this country. And it again is linked very strongly to determinants of health. And one of the things that CHF is doing is getting more interested in the social determinants of health and the issues there. So that's what was in the budget, and now Leanne, we think could have been in there.
What we would have liked to have seen in the budget, and you'll see us, we'll be releasing our election priorities that many of our members help us shape through member consultation forums and surveys we conducted in October, November towards the end of last year. We've obviously been holding off putting that out until there was a timely strategic opportunity to do that. That's now. See that come out in the next week or so, and we're hoping to get quite a bit of attention to that in the election campaign. But turning back to what we've seen put on the table in this budget and what we think's missing, I think probably the thing that really struck us was, of itself, there's a, as we said at the outset, there was a peppering or a myriad number of initiatives, but all of which in their own right have merit, no question about that. But it just seems to us that there's still a missing overall vision for where we want our health system to go. And that's not about announcing new money necessarily, but it is sort of expressing where all of these investments fit and sit in the context of a 10-year plan for Australia's health system. So we think that's missing, and other commentators are saying similarly. As Jo said, no substantive prevention measures. Quite a few of the things bundled into what was described as prevention were not so much population health level prevention measures, many, and there's good evidence base for those, but more targeted secondary prevention measures, which again of themselves are not bad or not lacking in evidence. But I suppose the big gap, and the one that we're really concerned about, is there's no coherent, concerted focus on tackling obesity. If there's any public health issue that's on the horizon that's going to have an impact on the sustainability and downstream costs for our system, it's that. It needs a strategy, and it wasn't there. As Jo said, we are very interested in the social determinants of health. It's very prominent in our company objects, actually, and in our current strategic plan. So we have joined with ACOS and many others to support the Raise the Rate New Start campaign to move people out of poverty and reduce health inequalities. If there's one single measure that could be done in the social determinants space, it would be to raise the New Start rate. So we're very passionate supporters of that, along with ACOS and the Business Council and pretty well everyone else in the community. No new dental funding. It's a huge area. Dental and oral health, affordability, access. You all know what I'm talking about there. We just saw a continuation of the child dental benefit scheme at existing levels. That was fine. But again, in terms of a health issue that's going to impact families, impact the development of other comorbid conditions, it's that one, and it needs some serious investment. No extra home care packages despite long waiting lists in aged care, huge oversight. And I guess while there was some doubt on primary care reform in terms of that measure that will pay GPs in flexible ways to provide more flexible services by email and Skype, phone, sort of non-face-to-face modes of service delivery that are going to be convenient for people, particularly the over 70s who often have, struggle transport-wise getting to GP surgery. Affordability if their GP doesn't bulk bill. This is a good measure, but I guess we were disappointed, and I think RECGP, the College of GPs, and others were equally disappointed that perhaps it wasn't as ambitious and progressive, transformational, and that the investment, while it's a welcome down payment, I think we were looking for more there as well, particularly looking for how we can invest more in supporting people to better self-manage in the community. If you saw our federal budget submission, we were looking for some investment in some programs that would better support people to self-manage their chronic conditions, because they're not going to the doctor all the time, nor should they be. There should be access to support programs and other services in the community that are not necessarily more consults with GPs, but are just designed to activate patients to want to self-manage, support them with their health literacy, and provide them with some pathways to community-based services that can help with lifestyle risk factor management and help sort of arrest, progression to more complex chronic condition issues. So look, I think that's probably it in terms of our overall appraisal of the budget.
So now we on this slide we've
Question?
got some more information, but now we might see if you've got any questions. So if you just bear with us while we get the questions up in front of us, and so that we can see what they are, then we'll try to address those as we go through. Bear with us.
So one question: will a new primary care enrolment model for old Australians over 70? So that's the cohort in the population, if you like, that we're talking about. It's not going to be for everyone. Will that still see GPs bulk billing? Depending on your GP, yes, it will. This is additional payments to GPs over and above what they would normally bill on a fee-for-service basis through Medicare. And it's really designed to give them the flexibility as a practice to provide more coordinated, responsive care. So they might choose to spend that money, on a non-dispensing pharmacist, for example, to be part of their practice team, to work with older people on medication review, medication regimes, that sort of thing. They might use it to extend some time and pay for more practice nurse time, and they will use it to cover the cost that they might spend on the phone to you doing a consultation by FaceTime or an over-the-phone consultation. I guess that's the other point too, that with the health, I suppose the forerunner initiative to this, the healthcare home program, which was quite, as we understand it, quite complex for practices to implement, because they had to use quite complex, risk stratification tools, and quite complicated for them to work out, which patients within their practice were eligible or not. We think the model of just taking age cohorts, starting with the over 70s, is a simpler way to go. It should be easier for practices to implement that. And I guess that life course approach, if you like, you can imagine how this sort of model could lend itself to, voluntary enrolment for other age cohorts as well, like, families with children under 5, for example, who are often high users of general practice services, but also where there's opportunity to reduce avoidable ED admissions. There's data that tells us that quite a lot of the avoidable ED admissions are in the mornings and in the evenings by of families with kids who they're pretty desperate and want to be assured that their children are okay, and often it's the ED where they go, whereas a more flexible general practice model with some phone support, that sort of thing, could be a good remedy for that.
So have we got any the next question?
So this is the will Consumers Health Forum be involved with the development of the web and content for the Out of Pocket Costs website? Yes, we will. We got a letter this week actually, and asking us and quite a few other consumer organisations too, which is a good thing. So we won't be the token consumer sitting there this time. Jo was our representative on the ministerial committee on that before, and was the sole consumer voice and representative on that, which, as you know, those of you who've done that job as a sole consumer rep, it can be quite challenging. So we'll be on a working group to design that and work on the consumer or community education program that's intended to be put in place to go alongside that. So I think Cancer Voices, the Breast Cancer Network, and there was another,
Cancer Australia,
are also going to be on that.
Another question there. I don't have any others. So look, we have logged all your questions and all your comments, so we will follow up when we put this up on our website and with a bit of an email bulletin post webinar if there's things we've left unanswered from today. So it all seems to have been incredibly self-explanatory. So we don't have many questions. If anybody has a question that comes to you after you've had a look at this or had a look at the fact sheets which are available on the Department of Health's website and everything, then you can always contact us and come back to us with questions, any detailed questions that you want. You can get to us through our info@chf.org.au email box, and we will answer your queries. So I think I might just comment there too, Richard. Just seeing your, sort of taking it more as a comment than a question, but just to give you a response to that. Richard's he's saying here that we've made mention of the social determinants of health approach and targeting serious health threats, but are we conscious of the health implications of climate change? The WA Sustainable Health Review tomorrow appears to be concentrating on this. I think just to comment there, Richard, we are absolutely conscious of that. You'll see when you see our election priorities, you know, one of the approaches that we're taking at CHF is where there are arguments that we think are well prosecuted, that we agree with, but that we don't necessarily feel like we have particular expertise in, we lend our support to those sorts of causes and calls to action by other coalitions or alliances a lot of the time, and we'll be doing some of that in our election platform. So what's another example of that? You know, we're members of the National Oral Health Alliance, for example. So where there are sort of organised coalitions advocating for various changes and reforms, we'll often jump on those wagons as supporters, rather than necessarily being the lead advocate or lead voice on it. Yeah, and obviously some other health organisations, such as the Royal Australasian College of Physicians, RACP, have come out and comment on climate change and the health implications. And so we will take their position and say, well, you know, we believe that they've done their research, that we would support them in what they're saying. So I think we can't be the experts on everything. We try. So we'll join with others, and we're always interested if people know of other calls, such as the RACP's call on health, on climate change and health implications. If people share that information with us, we're more than happy to have a look at it. You can see our numbers are starting to dwindle in the corner of our little chat box there. So I think unless there's any more questions, thank you for listening in. We will sign off, and I believe this will be up on our YouTube channel. So if colleagues or others want to have a look at it and refer to the slides, you can do so there. So thank you very much. Thank you.